Thank you for coming. I especially want to thank the patients, me and some of you who've been on this journey together for a really long time. So I recognize a lot of your faces, and so thank you for spending today with us. And hopefully you took a lot away from these incredible speakers. Whether you know it or not, you've been in a room full of really fantastic clinicians today. We are super fortunate, not only at our institution, but in the entire city to have these physicians on board. So thank you so much. I've been too fortunate to work in EP for longer than I care to talk about, but I'm going to talk to you about kind of like what your journey looks like with UC. So I'm going to take a moment to talk about what we call integrated electrophysiology care coordination pathway. And what it really means for our patients. So at its core, it's about access, coordination, and prevention. First, it's rapid access. We know that you're experiencing something like they talked about today, palpitations, fatigue, AFib. It's not just uncomfortable, it's pretty scary. And I know it gives you anxiety. So you want answers quickly, and so we built a system where patients can get care fast, often within 2 weeks. That's our goal. So you can hold me to that the next time you call for an appointment. And then second is multidisciplinary collaboration. AFib is not managed by just one provider, like we talked about all day. It does truly take a team. Our EP doctors, neurologists, surgeons, primary care providers are all connected, but even more importantly, something I want to talk to you about is your connection to people like myself, coordinators, nurses, and kind of what we do, Nikki, on the backside, of their care. So you see your physicians, but there's a lot of us kind of on the backside doing things, coordinating your testing, reviewing your referrals, planning your procedures like ablation, surgical ablations, testing, and our goal is to make sure that nothing falls through the cracks. And then finally, we have obviously a strong focus on stroke prevention because this is one of the most important parts of AFib care. So every patient we evaluate individually to determine their stroke risk. We talked about CHA2DS2, probably you've memorized that. And like whether we're going to push on blood thinners, whether we're going to do a left atrial appendage closure. So that's kind of what us coordinators do on the back end. You don't always see us probably. Why this model works, we talked about, what we do, but why do we do it this way? And it really comes down to you having access to your providers and to us. Like I said, our average time for referral to visit is less than 2 weeks. Sounds simple, but in today's healthcare environment, that's a huge deal. So patients with AFib are often symptomatic, anxious, and looking for answers. And if we can get you in quickly, we can start your evaluation, provide reassurance, and initiate the plan to escalate your care. We offer same-week access for symptomatic patients. So if you don't know that, we do now. You can contact me or the clinics or however, whatever number you have to access us. So we have special slots saved for you. So if you're not feeling well, don't wait. And if it's not an emergency and you want to get to the clinic, give us a call. We have spots to see you. And another major piece in is our dedicated emergency department discharge and urgent access slot. So we've worked really, really hard with something we haven't talked about a lot is our emergency department team. We build a pathway for them to get you to us quickly and efficiently. So if you do find yourself in the emergency room, then we try to get you back in front of us as soon as possible. And then coordinated multidisciplinary decision making. I know you've heard this all morning, but this is where everything comes together. Instead of fragmented care, we bring you to the right people, we bring the right people to the table. And Dr. Scott, we had a great little visionary of that, but they do come to the table, whether it's over the telephone or our lovely Epic system. It's primary care, surgery, neurology, electrophysiology, and we do talk about your plans. So it is truly a team-based system. And then we talked about how do we get patients in the door here. So you come in a lot of different ways. You probably all know that. So there's no single right doors that come in for evaluation for AFib. Most traditional pathways to your primary care doctor. So you see your primary care doctor, and sometimes it's just on your physical, and they find that you have AFib. And our primary care physicians are great about reaching out to us directly for patients who have new onset AFib. We also see a large number of patients coming through the emergency room. We would like to decrease that, so we look to find spots to get out of the emergency room, but if you find yourself in an acute event, that's a stressful experience. We have special ways for you to come to see us. And then one thing that we talked about today, and I know Dr. Tam talked about it, is we find patients coming to us from wearable devices. So good old Apple Watch tells you that you have AFib, and that's how we're getting a lot of our patients nowadays. And then social media outreach. So I have a great partnership with our marketing here not today, but we try to reach out through social media. Facebook, Twitter, whatever all the other things are nowadays. But we have them all. We do them all to try to keep you updated on what we offer and how to get in touch with us. And then we have a dedicated phone line that some people don't know about. And I know they don't know about it when it comes to me. And the only people that ever call me are about renewing my car insurance policy or if I want to sell my house. But no one has told me where I'm supposed to live if I sell my house. But they do. That's the only people that call that number. So it is 584-EPEP. So you can call that at any time. I'm obviously not there overnight, but I'm there throughout the day. And I have voicemails. So you can always ask questions, leave me a voicemail. I'll get back with you. This slide kind of highlights one of the most important parts of the process, and that's centralized intake and triage system. So within 24 to 48 hours of a referral coming in for AFib, that referral is reviewed by myself or one of the other team members. And that makes a big difference because I know you've probably all followed a phone tree system, and bless the hearts of the poor people that answer those calls, but sometimes you just kind of feel like you're out, you've been left out into the world. Well, there are human beings looking at referrals to come in for AFib. Our triage process is led by mostly our advanced practice providers. Unfortunately, most of them not be with us today, but we have a phenomenal team of nurse practitioners who many of you probably see. Our neck surgery has wonderful advanced practice providers. And they do a great job at helping me assess and probably helping me assess who needs to go where and when we need to get you there. So, and then from there, patients are stratified into categories. We have urgent, symptomatic, or routine. And this step is key because, like we talked about, not all AFib is the same level of urgency, right? So someone who's highly symptomatic, we should see them go over to see routine follow-ups. And then based on clinical prioritization, we move into rapid scheduling. Instead of a one size fits all approach, we match by making the patient's needs. So we hope to create clarity and confidence for you when you are trying to get in to see our providers. And then what happens at your initial visit? This is obviously your initial evaluation visit. AFib care is changing, as you see, and we hope to make more dedicated AFib clinics where patients are getting, lots of education. I know a patient came up to me and said, I've learned so much more today than I learned in my office visit. And while I'm great, I'm super thrilled that you came today and learned this, I wish that you had the time to learn these things in the clinic. So we hope to move a model more where you're getting more education and we partner with the surgeons and you're getting education on, what can we do, where are we going from here, and what you can do, for your own journey. So more on that, but we begin with your symptom assessment. AFib looks very different from one person to another. Some patients obviously have the palpitations and shortness of breath, and then others are shocked when we tell them they have AFib. They just have no idea. So, and we take a detailed AFib history of them. When did it start? How often are you having these episodes? Do you know a trigger? I don't know if we talked a lot about triggers today, but it's one of the most common things I get asked is, did I do something to cause my AFib? Is there something that I did to cause my AFib? So, we talked about in certain cases, there are things that trigger AFib in patients. So, we talked about those things in your initial visit. Medication reconciliation is another key step that you see and really is something that I'm passionate about. Epic is great. The downfall to Epic is that if you are seeing a TriHealth and you have a doctor here, you see a doctor there and price, and sometimes those medications get pulled all over and it's really confusing for you when you get a piece of paper every after visit summary and has medications you're not taking. So I hope that someone is doing comprehensive medication assessment with you when you're coming in to see us. You want to make sure, especially with antiarrhythmics, I know our physicians talk about it, they interact with more things than they don't interact with. So it's important to know what you're on. And then, of course, the vital part is your stroke risk, your CHA2DS2-VASc score. If you have a Watchman, or you talked about a Watchman, you talked with me probably about your CHA2DS2-VASc score. We talked about that today. It's very important. Again, not everyone's stroke risk is equal, but it's real in all AFibs. So we try to have a conversation about how we're going to mitigate your risk of stroke. And finally, where the shared decision making comes in, right? Because our physicians and nurses can tell us, you know, what they think we should do, but really ultimately comes down to what's going to work for you in your life. And we want to make sure that, you know, we're establishing trust and that you know, that they're not just making decisions for you. It really is it's your decision. Multidisciplinary care coordination. I think we talked about this quite a bit today, but there are a lot of people working behind the scenes on your care. And I know sometimes you may send a message or you may call and it feels like no one is getting back to you, and that's super frustrating. And I hope that that is not the case, but sometimes what's happening is there's just some little person in the background and trying to get all the pieces together for you. I spend probably about 50% of my time talking to your other providers. So where Dr. Rochecker may come to me and say, I recommend this for Ms. Smith, but I need you to reach out to everyone, you know, that they see and make sure that we're all on board with the plan. Sometimes that takes time. And so some, you know, those are things that we're doing kind of behind the scenes. And I hope that that you feel that we're involving everyone in your care, and again, not just making this as a single person decision. For more advanced complex cases, cardiac surgery becomes involved, and like we're super fortunate to have them here to support other ways to treat your AFib. And hopefully you guys thought this was as cool as I did. So neurology is a key partner. Also, if you've had a stroke or you've been suspected of a stroke, or you've been in the hospital or you moved someone, you may have also talked about, you know, there's a stroke pathway when you're in the hospital for AFib, whether or not you get a loop recorder, and we do for monitoring and how that works. So there's a kind of a pathway for everything, and then primary care plays a critical role in your long-term management. It's very important that, you know, we keep them abreast of what's going on in your care, and importantly, you talk to them about what's going on. We serve as the central hub, coordinators. We refer, or when you review referrals, we facilitate communication, coordinate procedures, make sure you don't get lost in the process. That's who we are. And then let's see, how do we stay connected? So as you can imagine, our physicians are incredibly busy people. So they cover a multitude of locations. We have Westchester, we have VA Medical Center that a lot of our physicians come to. Obviously, they're here. So it really talks, there's a lot of moving parts to keeping you connected, but we rely heavily on direct provider to provider communications. Like Dr. Spadaccio says, you may have Dr. Raj on speed dial. So, you know, they really are talking. The decisions need to be made. They doesn't happen in isolation. You know, sometimes it is, we really need to come to a round table to have a discussion. We also utilize shared electronic medical records, like we talked about. So we can kind of all see what's going on, even if it's happening outside of our system. And then coordinators are in care pathways, again, as your care coordinators, and then rapid escalation, and then just all the things that you can imagine. Sometimes I say keeping physicians and in line and treating AFibs like herding cats. So it's kind of what it's like, but it's all for the good, for, you know, to make sure you're all taken care of. But after we treat you, and I know Dr. Ross talked about, you know, what happens next. One of the first things we need to address is medication and adjustments. After a procedure like ablation or cardioversion or even surgery, ongoing medical management medications need to be reassessed. So you may hear from a coordinator, you may hear from a MICI, you may hear from me, you may hear from the clinic nurses. And sometimes we need to make adjustments to medications based on what we're seeing remotely. So we're doing that all the time. Symptom monitoring, key part of follow-up. We encourage you to talk to us about how you feel. We talked about wearable devices. If they're doing your blood pressure, and, you know, they don't ever feel like you're bothering us, asking if this is normal, or do you mind to take a look at, you know, this strip that I got for my watch and I'm worried about an AFib. That is really, truly what we are doing. So, you know, if you ever have symptom questions, give us a call or my chart or whatever you like. In addition to symptoms, we rely on rhythm surveillance, which we talked about, EKG, short-term monitors, loop recorders. All of that is just part of the piece of us making sure that you are on the road to recovery. And then follow-up care model, you probably see a nurse practitioner quite a bit. So we have routine clinic visits, remote monitoring, access to nurses and coordinators. You may not realize that there are coordinators and people that you can also talk to. So if you have questions and you feel like, I really don't want to, hopefully I need to talk to Dr. Sam. Ask to speak to me, ask to speak to the clinic, the coordinator thing, and we can usually help answer a lot of questions. And then make sure that you ask for a clear symptom escalation plan when you're in clinic. So it's, what do I do? When do I call you? What are, when do you want to hear from me? What are the next steps? When do I need to go to the emergency room? Because I think that is what gets missed in clinic a lot, right? You leave and you think, oh gosh, I don't know. Well, I don't know if I'm supposed to go to the emergency. Did they say this is normal? We can provide that. You can always reach out to us and we can help you with that. So key takeaways, rapid access to care, structured and efficient pathway, strong multidisciplinary collaboration, clear communication, patient-centered coordinated care. Oh, I cannot leave you all without talking to you about the region's one and only AFib support group. I would just be doing you all of this service. So many of you come to our AFib support groups, but if you have not heard from me about the AFib support group, and you are interested in coming to that, we usually hold it about every 3 months. We go back from between main campus in Westchester, and we are going to be able to do it remotely soon. But AFib can feel overwhelming and isolating, and you have symptoms of anxiety, and all you keep hearing is that, well, AFib's not going to kill me, but that doesn't mean they don't still feel bad or it's not so scary. So when you come to our support group, we're here to answer whatever questions at your disposal. I usually have an EP doctor there, or we have neurology sometimes. Sometimes we have industry people join us. We talk about patients, we talk about procedures, we talk about what's on the horizon, what we are going to be using next year. Probably a couple of years ago, we talked about cardiac surgery before we really, about our event plus system. What's normal versus what's not normal. And you are all welcome to come. We know that you don't just need treatment, you need support, and I hope that that's what we can provide for you. I hope that you took away lots of good information that you can share with all your friends at your next outing, and I'm always here to help you, really. Call me at any time. 584-EPEP. It'd be really nice if that number rang and it wasn't a spam call, right, Lisa? Any questions?
Good. Thanks very much. And just looking for a moment of today. Please join us.
I'm not going to talk. No. Just kidding.
Well, which is very nice, wonderful. Thanks very much for being here. It's touchy for me, but we had a long history, and very glad to see how we do. So it has been a complex patient because she came to us some issues with the filtration, and after some times people decisions, we figured probably the best way forward was to do a surgical patient. And we discussed it with you and then we started to do some tests, some modeling of the chest and everything. And then we would also have some potential problems, and they were not related to the heart. But unfortunately, here we see we have a very large team, and we involved also the plastic surgeon and the ENT surgeon, and then eventually managed to navigate her to a robotic procedure, and we was very proud. Beautiful, beautiful results, and we are so glad to be here, and we will like really to have the opportunity to listen from your side, from your word, how things will be going on, and so that everyone is inspired and help out other people in this world.
I've been a patient of Dr. Rosheffer since 2023. And I had 3 elevations and 3 cardiograms, and they worked for a while. But then the AFib came back. And I was at a visit with Dr. Rosheffer, and he said, how are you feeling? I said, I'm fatigued, I'm anxious, and the quality of life just wasn't good. And he referred me to that patient. And I had my surgery September 30th, Tuesday, and I was in the hospital till Saturday. He's right about the nerve involvement. I have very little pain from the surgery. And my fatigue is gone. I'm losing weight. I can move around, and I'm not anxious anymore. I also got a new 3/4. I got a new 3/4. And I feel a little relaxed. I was very anxious with the AFib. It was constantly on my mind. And the fatigue, I've got a 92-year-old brother that runs circles with me. And fatigue is gone. And I'd suggest it to anyone who's tried everything else, and it doesn't work. But I feel great. One few doctors said you see. Luckily, all my doctors are here, so my Charlie's up there. Yeah, I've had AFib since 2019. But I think I had a lot longer than that. My primary diagnosis, I got. So,
That's good. Please for you, Michelle, and for them.
and I tell everybody when I have doctor's appointments, I mention it to them, tell them all about the surgery. That was an awesome. It was an awesome.
Well, thanks so much. He's open to the audience. Any questions, any other, please.
I don't know if you want to talk about it, but what other symptoms do you have? What other conditions do you have?
Conditions.
Diabetes.
I don't have diabetes, I have high blood pressure. I have high blood pressure, psoriatic arthritis, osteoarthritis.
You got.
Hmm?
You got.
Sleep apnea, I do wear a CPAP machine every night. I keep paying for so many things. Those are the major problems I've had. So you mentioned minimal pain? Minimal pain, yes. I had an incision here, and one here. Full incision. And I had a lot of numbness, and a little bit. And I could feel the nerves coming back every once in a while, like the jolt. And my cardiologist, Dr. Lakeley, said, your nerves are regenerating. Is that right?
Correct.
But it's been a process, and I feel better every day.
And I'm glad you had your kids back for that.
Pardon me? My energy, oh yes, yes. The other day, I have a chair that takes me up and down the stairs. My sister-in-law had it when she lived with us. And the other day, I've been riding it, because I figured it's there, I might as well ride it. The other day I ran down with some exciting news to tell my brother. And I turned around and thought, I just came down the stairs. So now I'm gonna have to start going more often.
Right? This means that if it is out of the mind now. It's good.
It's,
Absolutely.
you still see that much.
Of course. Let's say that. No, but as well. So.
After the procedure, after her procedure of Becca's posture, we brought her back to do the mapping. Everything was, all the trigger spots for the atrial fibrillation were now gone. So it was good. Proceeded well. Happy to see.
Yeah, I had the surgery on the 30th of September, and then the day after Thanksgiving, I had an ablation. And early March, I had a loop recorder. 2 weeks later, I had a TEE. So,
Lots of checks.
yes. Yeah. And Mickey is home.
Yeah, we need to have a big round of applause for me.
Thank you.
Well, thank you, thanks so much, and so I'm gonna leave for you. Just a moment. Being talking of appreciation of the mother in law that the next generation. So I would say we're probably running a little bit on time. I am really interested of sending them on home. First of all, ask me online. It's correct.
So I only had one outstanding question for online,
Yes.
and that was a little off topic, but a little on. Can you touch on the training required to become an EP specialist?
Oh.
Oh, that's a.
Lots.
So I went through 4 years of medical school, and had a 3 years of internal medicine residency. And after that, we have 3 years of cardiology fellowship, followed by 2 more years of specialized EP, training.
And you look so good.
So we'll probably conclude. We'll probably conclude here. That's like. You take home message that we can see out of all the talks that we have. So first of all, finding a team is a team sport. Okay, you are very involved with this, and we are involved with you. We are all together. Once again, this is not a one size fits all approach, and it's actually is the approach that best fits the patient that we have in front of us. That's the reason why there is a lot of discussion among us and a lot of teamwork. Another important point, time matters in AFib management. So please, in the way of you start to have symptoms, you feel symptoms, or somebody is even with the perspective being involved in patient population, reach out to the security, reach out to the network, or reach out even directly us, because this is a high specialization condition, and you need to specialize team for approaching, and the earlier we do it, the better it is. Another thing that I really want to emphasize, because I'm sure that both online and here in this room, there will be still people affected by the faith. It's still there. Somehow it's still there despite all the different treatments that we give apply. And it's important to understand that in anything, this file, the goal is not really to, shut it down overnight and every time it lasts forever. I mean, this would be ideal, but it's really not the circumstance. As we show, the clinical trials that we've been discussing today, the actual results of these things are very good, but they're not 100%. The cure is not there 100%. And sometimes the goal is not really to shut it down completely, but just to reduce the burden of it. Because as a matter of fact, is that AC burden, how time it happens and how much time it happens that leads to the complication, and reducing the burden of it will improve the quality of life, will improve the serenity of your sleep within the day. And I would say finally, when we need to approach patient in a more aggressive way, like the procedure, I would say we're proud to say that here you see we don't really simply perform the procedure. We really build a patient specific plan. And that's the thing we are proud of, and that's the thing we are like to portray and leave as a message in the community. And with this, I would say we will thank our partners, many partners for being phenomenal, and thanks a lot for all these support for giving us. Actually, we were, of course, one of our video partners, and I really want to have a very special thank to the organizers here because really, Sheila, Thor, they've done a phenomenal work and they managed to make all this happen. And most importantly, I must also thank Chance because you see her behind the column, but is being phenomenal. So with this, I really wish you a really pleasant afternoon. Thank you. Thanks a lot.